Okay, so right now we're just going to let the attendees join the meeting. Let's just give them 1 or 2 minutes.
Okay.
So a very good morning to all of you. Good morning. Yeah. And thank you for taking the time to register to attend this webinar from Cancer Research Malaysia. I know some of you may have already seen me many times. Some of you, it may be the first time. But for those who are really consistent in their webinar attendance, all the webinars from Cancer Research Malaysia, thank you so much for your support. And for those who are first timers, you've never attended a webinar from Cancer Research Malaysia before. So welcome, and I hope that you find our webinars informative and also enlightening so that you'll be able to learn more about what we do here as an organization. Okay, so we have quite a number of people, but since it's already 1 minute past 11, let's get this webinar started, all right? So without further ado, again, welcome everyone who is present today for this month's webinar. So today, our topic is the calculator helping Asian women fight breast cancer. So we want to know if your risk is hidden in your DNA or your genes. And today we have a very special guest, one of my colleagues from Cancer Research Malaysia. She is Dr. Boon Hong. So she's right over here. So hi, Boon Hong. How are you feeling today, this morning?
Hi, Amanda. Hi, everyone. And I'm Boon Hong again. Thank you for having me here today. I'm good. I'm good. A bit nervous, but I'm good.
Just a bit nervous. Yeah, don't worry. It's just you and I. Yeah. Okay, so no nervousness. And so, yeah, so it's great that you can join us today. So basically what the whole thing is going to be about is that we are going to talk a bit about her role here at Cancer Research Malaysia, because she's one of our scientists, a postdoctoral scientist, right? If I'm correct, Boon Hong. Yeah, absolutely. So glad I got that right. So we want to know about one of Cancer Research Malaysia's developments, which is called ARiCa. So ARiCa is, you can call it a tool or a calculator, because that's what the title implies. So ARiCa is something that can help doctors and also breast cancer patients. So since, well, I just mentioned about breast cancer patients, you know what sort of direction that we're going to. So we're also going to talk a bit about the situation of breast cancer here in Malaysia, how it affects women, and how did Boon Hong and her team come up with the idea for ARiCa in order to help these patients. So let us get straight into the questions. Boon Hong, all right. So first, can you tell us just a little about yourself and what is the role that you play at Cancer Research Malaysia?
Yeah. So again, I joined Cancer Research Malaysia as a postdoctoral scientist. So I'm parked under a team, this Cancer Prevention and Population Science Unit. So and I'm trained in statistics and public health. So basically, I work with numbers a lot. So within our team, broader mission is basically to reduce cancer burden through prevention or even early detection. So basically my job focus is to translate like mathematical models, like solutions, into practical or tangible tools that you can use in a clinical setting, and or even as strategies, like a screening strategies to help women understand their own risk and also possibly get the right tests at the right time.
Right. So you have to do like a lot of data collection. You have to work with a lot of numbers, right? Sounds like a nightmare. I'm not good with mathematics, despite the stereotype. Yeah, I'm not good at it, unfortunately. So I do envy you.
Yeah, we work with numbers a lot, the pre-collected data. So I'm not directly involved in data collection. So technically it's data collected by another team. So what I do is I access data and do some mathematical modeling.
Yeah, but either way, you still have to deal with numbers, right? I mean, honestly, you cannot escape from numbers in this world, no matter what you do. But wow, sounds like a really, actually, yeah, I get that the role of a scientist is usually very complicated. And usually for regular people like me who are not scientists, we sort of get like intimidated about it, we feel that, oh, those people are like so so way up, you know what I mean? But then again, that's like another reason why I invited you here to speak to all of these people who are present today, so that, it is actually easy to communicate with a scientist because they're just humans, just like the rest of us. And also at the same time, know a bit more about your work. So, and then, well, moving on to the next question. So what is the current situation of breast cancer here in Malaysia? So now we all know that breast cancer is like the number one cancer affecting women, not just in Malaysia, but also everywhere else across the world. And it's quite scary because I have personally known, I'm sure we all know someone at some point in our lives, whether it's our family or friends or distant relatives, who have been affected by breast cancer. And some of them, unfortunately, maybe have passed away, or some of them have survived breast cancer, but they have to like cut off their breast, the mastectomy and all of that. So I'm sure that we're all familiar with someone who was affected with breast cancer or is affected by breast cancer. So maybe can you tell me a bit more about what's the issue going on in Malaysia? Are there any important updates that we should know about? Anything important, anything facts that you think that the Malaysian public should be aware of?
Okay, I think there's a common statement whenever there's a talk about breast cancer.
Yeah,
Breast cancer
yeah.
is the most common cancer among Malaysian women, and it's also the one of the top cause of death in women and in our Malaysian setting. If you were to look from a statistical, just to give a rough idea about how frequent does these happens in our population, it's about 1 in 20 will develop breast cancer in their lifetime. But this average number is still very similar to the global average reported by World Health Organization. But again, we all know that our country is multiracial, right?
Yes.
So we have Malay, Chinese, and Indian. We are all different. Given the differences, if you were to look at these breakdown by ethnicity, we do see a higher rate, especially for Chinese and Indian. And these rates are a lot higher than the global average. And we do see that in Malaysian setting, many cases are still detected at late stages, like stage 3 or stage 4, when it's a lot harder to treat. So that's the current status. If you were to look at statistic-wise in Malaysia, we do see an increasing incidence year by year. More younger individuals are being diagnosed. It's no longer like 50 years and above only are getting diagnosed with cancers. We do see a trend where younger individuals at 30 and 40s are being diagnosed. So, and because there's no proper screening, we're seeing more and more cases are being detected late. So there's no push for an early detection in our setting. Yeah.
Well, that actually sounds scary because you mentioned about two things. You said that the Chinese and also the Indian populations are more prone to breast cancer as compared to maybe the Malay population. So just right off the bat, I would think it's because of our DNA. And DNA is exactly what we're talking about today. And secondly, you also mentioned that younger people are like coming forward and getting diagnosed with breast cancer. And that's quite scary because I think it's a general statement that people assume that the older you get, the more likely you are to develop cancer. But is there a reason why, younger people are getting more diagnosed, or is it because they are getting diagnosed early? Because you did mention that some people come in late and it's already stage 3 and stage 4. So maybe that's the reason why. Is it because of the time gap?
It's not because of time gap. I think if you were to compare in terms of age of diagnosis for breast cancer, if you were to compare Asian and European, we are 10 years younger.
10 years younger, yeah.
On average, our the average for age of diagnosis is 10 years younger compared to Europeans. If Europeans you're detecting 50 years and above, we are seeing more trends of 40 to 50s. So we are seeing a younger age trends in our Asian setting. So it could be because of genetic settings. We are genetically different from the Europeans. So one of the reasons why genetic studies are becoming more and more important in Asian setting. If you look at 10 years or 20 years ago, we do see that 90% of studies, genetic studies, are all Europeans. And that's the
Absolutely.
reason why we tend to apply their guidelines in our setting. But now we do see a trend that those trends that we observe in Europe, it doesn't apply in ours. That's the reason why we're having more genetic studies, which is one of which Cancer Research Malaysia is building upon. We're having more genetic studies, and many teams are actually building the data from scratch, where we want to actually have a space on the spot on a genetic map. So we have more Asian studies contributing, because to show that we are genetically different, one of the reasons why we're having more younger people are diagnosed a lot earlier in our setting. It's not because some are coming early or late, it's because our genetic differences, and because we are and when you are diagnosed younger, you're also prone to a more aggressive cancers, which also means if you're detected later for aggressive cancers, harder to treat and poorer survival. So in our setting, yes.
Sounds like a very, very serious problem, actually. Should I be concerned? Should we all be concerned about this, actually?
Yes. For Asian setting, yes. I think if you look at broader in terms of global stats, I think we are still lower overall in terms of global incidences, in terms of death, but we are going up in a steep direction. So we are catching up with the European setting. But if you look at in European setting, in 20 years to come, their rates are a lot more stabilizing, which means mainly because they have a mature screening programs in place, they also have a more advanced treatment, which are received in a timely manner. So that's the reason why they are plateauing. We are increasing like a roadmap. So it's a steep increase in Asian.
I
Yes.
see. Yeah.
And
So
if you look at global setting, more than half actually Asians for
yeah,
cases of breast cancer.
yeah,
More than half.
absolutely,
Yeah.
absolutely, yeah. But I think I can more or less understand what you meant. So you're saying that a lot of our beliefs and the facts that we have about cancer right now, it's mostly derivative from European countries.
True.
Because they're like sort of like the first people to actually go out there and do research. And when they came back with their own findings, they sort of like applied it everywhere. And we somehow didn't take into account that we are genetically different. So that's why right now it's not even safe to assume that for us Asians, like the older we get, the likely we are to, get cancer. So it's quite concerning actually. But yeah, so that's the whole reason why research is done in the first place. That's why it's so important, so that we can identify these differences that we have in terms of our DNA and our genes as compared to our European counterparts, so that if, say for example, if Malaysian scientists do research on the Malaysian population, then they would be able to find things that benefit us Malaysians. So hopefully I got that right.
Yes, you're right.
Okay, perfect. Because if I said something wrong, just feel free to correct me, because I'm trying to like break down and digest and make it easier for everyone to understand. Okay, so now that we know what sort of a situation that we have here in Malaysia, my next question to you is, how is breast cancer inherited, and what are the ways to detect it?
Okay. Again, I'm back to stats. Numbers first. So about 5 to 10% are due to gene or DNA changes. People would understand
That's actually a very small percentage.
Yes, very small percentage, but they can be lethal once you have it. So they are very rare in a population, but it runs in the family. So for example, just give a situation, if a mom is diagnosed with breast cancer and this mom is a BRCA carrier, let's say she runs a genetic test and she finds to be a BRCA carrier, her children will have about 50% chance of carrying the same mutation. That is scary, because if someone carries such a mutation, their risk of developing breast cancer in future is a lot higher, about 45 to 55% higher, which is alarming. So one of the ways that we can detect this is to identify it by looking at your detailed family cancer history. That's one way that we commonly do as a practice. And if appropriate, then the genetic test will follow in order to identify whether you carry a mutation or not. So if you consider in our setting at the moment, the genetic testing is usually offered, especially if you have a member that is diagnosed a lot earlier, like as I mentioned, 30 and 40 diagnosed. So usually those who are diagnosed younger, they will have a higher tendency, they are likely to carry this mutation. That is why it's triggering them to be to have early diagnosis at younger age. And also for those with a very strong family history, means you have multiple relatives that are affected with cancer. So yeah, that's the how.
So it's so in terms of the considering the inheritance, you mentioned about the BRCA gene. So the BRCA gene is considered a mutation, or is it like something that we all have? But if the gene decides to go a bit crazy one day and it turns bad, then it becomes breast cancer or something else, right? So that's what BRCA gene is, right? Yeah, because some people may not be aware of what is this BRCA. It's BRCA, and then I think there is BRCA1, and also there is BRCA2. So in order to avoid confusion, we're just trying to keep it simple. But yeah, either way, I think so. Just to clarify 100%, so we are all born with the BRCA gene. We all have it in us.
Yeah.
But
Yeah.
it's just a matter of luck and possibility for this gene to go weird and abnormal one day, and then it would develop into a very serious cancer, which is, it could be breast cancer. I'm sure there are other cancers which BRCA can lead to, but we keep it simple. Let's just stick to breast cancer for now. Okay. So and since you said that, well, this is inheritance, so I guess the easiest way to determine that we have this BRCA mutation is to do some tests. And also, if you have a family history, like say, for example, your grandmother, she got cancer and maybe she passed away from it, and then your mom also had cancer. So it's like if you're seeing a pattern in your own family history and your family tree, that is a very, very strong indication that you have a mutation.
True.
The BRCA mutation. Okay, so I think that's a bit like common sense, because it doesn't really take much to figure out that there's a pattern, right? So obviously, if you're seeing that your family somehow has like numerous cases of cancer, then it's already a telltale sign. It's quite obvious that you should be concerned about your risk, and that you should definitely go and get tested and see whether or not you have that risk. Okay, perfect, great. Glad that I got that all. Hopefully I didn't mess things up. Okay, so now then, why is it so important for us to know about this risk? Why is it so important for us to be aware of it? And what are the sort of services and what are the sort of tests that we can do to find out more about our cancer risk?
Okay. Again, everyone say this is a month where we also promoting awareness. So awareness matters, of course. As I mentioned earlier, in Malaysian setting, many women are still diagnosed at late stage. And there's two things we all need to know. Never think that you are not at risk. And cancer can happen to anybody in these days. And the second, we are different from Europeans. That's one. Number two, we, even within our own population, we are genetically different, Chinese, Malay, and Indian. And individually, we are also different because of the different habits that we adopt. So we are different from each other. So the risk is going to differ individually as well. So knowing your own risk can actually help you to get the right tests at the right time. So for example, like if you know your own risk, your genetic services. So the value that genetic services adds to this process is that it offers a genetic counseling and then followed by genetic testing so that you can identify whether you inherit certain risks. So if a mutation is found, a woman who knows their breast cancer, their BRCA gene status, for example, they can choose to start screening a lot earlier or even frequently with a shorter screening intervals. They can also consider like a risk reducing strategies, like a prevention strategies to reduce their risk, like surgical options. And also inform healthy relatives, actually, those who are close to them, through a cascade genetic testing. We call it a cascade genetic testing, where we spread to their related close individuals. And then so that the whole family can benefit from this testing as well. So it's not just about having the test positive that is beneficial. Even if the test is negative, the counseling session that we have pre and post counseling after the genetic testing, the post counseling will actually help you to tailor a personal plan, even for potential screening or prevention strategies. So that's how I think genetic services adds in a value for this.
Okay. So a lot of people may not actually be aware about these genetic services here in Malaysia, because I personally think that it's still a bit new and it has yet to enter the mainstream in hospitals. So maybe in some major hospitals like Subang Jaya Medical Center, where our office is located, yeah, genetic services is provided, but a lot of people have never even heard of it and they have no clue about what it is about. But as you've mentioned, that's why it's really important for us to spread awareness in the first place, because this is something that can be preventable. I mean, in terms of the cancer, you can absolutely prevent it just by taking note of your family history. And if you see that there's a pattern, then you can immediately engage in genetic services. So you do things like genetic counseling, as you've mentioned. I think the process is that you say that you're interested, and then you will have a pre-counseling session just to make sure that you are eligible for the test, and then you do the test after you give consent. So the test, I believe it's saliva or blood, right, Boon Hong?
True, saliva or blood.
Okay, so saliva is just like the COVID-19. Is it like the same thing? Is it the same thing?
They collect in a tube and you have a lab test. It's just not like a rapid test. It's not a rapid test.
It's just not like that, right? But you have to provide saliva, and then for blood, it's the same old that we're all familiar with.
Correct.
Okay, so after the test is done, and then you will have the post-counseling. So that's when your results are already released from the lab, and then the genetic counselor will be discussing with you about your results, because there's no way you can understand all of that yourself, right? It's just like having your regular blood test, and then you get the report. It's like a whole stack of papers, right? And then you read through it and you're like, what are all these numbers and what are all these terms? I'm sure we've all like tried to read it before and we got really confused, but that's the reason why the doctor is there in the first place. So you can sort of like apply similarities between the blood test and the doctor, and also the genetic test and the genetic counselor. Yeah, so that's one way I can think right off the bat on how to relate it, so that people would actually understand what genetic testing is and who genetic counselors are. Okay, perfect. So we have talked a bit about breast cancer, and we have also talked about inheritance. We've talked about BRCA genes and mutations. Like, wow, this is all like really heavy sciencey stuff, right? I hope they're not intimidated. I hope that the audience is still following what we're saying. But okay, so now we can finally talk about ARiCa. All right, so we have these problems in Malaysia. We know what is the current issue on breast cancer, how it's a serious problem. And then we know that people are detecting it late stage, coming in late at stage 3 and stage 4. So what exactly is ARiCa, and how can it make a difference for Asian women like you and I?
Okay. So basically what ARiCa here, so ARiCa is Asian risk calculator. So the short name is ARiCa. So if you, again, as what you have mentioned, Amanda, so in countries like Malaysia, where we have limited resources, we have a limited trained genetic counselors at the moment. So in order to accommodate a large number of patients for genetic testing, so we will even healthy individual for genetic testing. So probably because of these limited resources, we probably need an efficient tool to select individual who would benefit the most for genetic testing and make use of the resources efficiently. So one of the way to do it, that is the reason why we at Cancer Research Malaysia, CPPS team, what we have done is we came up with this tool called ARiCa to help Asian women who are diagnosed with breast cancer to check their chance of carrying a BRCA1 or BRCA2 mutation. So what this model does, it's a mathematical model, but it has a very simple basic information that is already pre-collected in a medical setting, especially for breast cancer patients who is already attended by a clinicians in a hospital setting. So informations like age of diagnosis, like tumor type, and also family cancer history. Again, family cancer history is very important component also in this model to provide you a rough estimation of what is your probability of carrying the risk. So the probability here is like a percentage. Just imagine it's between 0 to 100%. The higher the percent means the higher the risk of you carrying such mutation. So it uses a very basic information that has been pre-collected. So how it helps is that it helps both the clinicians or the doctors, as well as the patients, to make a shared informed decision. So it's like a two-way mutual respect, both of them discussing on what's the next plan. So if a genetic testing is needed, then the referral will be given by the doctors where they go and meet a genetic counselor. So subsequently, again, what you mentioned, Amanda, post-counseling, where they discuss every details from the papers, what is the results and what's the next step. And after that, that's when it goes back to the clinicians where they plan a better treatment for patients' view. And if they do carry a mutation, then the cascade testing comes in where your family members would also benefit. So if your score is high, we have a certain threshold. So if you above a certain threshold, and you will be advised to see a genetic counselor, and you will learn more about your risk by looking at your detailed family cancer history, and then you can decide whether you want to take the subsequent genetic test, just like what you have mentioned, using blood and saliva, which can be arranged. Yeah.
Okay, so I'm quite curious actually. Is it possible for anyone to use ARiCa, or is it just like only reserved for the doctors and the clinicians?
So at the moment, the way that ARiCa is built is a tool that is more user-friendly for a clinician setting. So one of the reasons is also because it's also V1 has more of shared informed decisions between the clinicians and also patients, because it involves the decision making in the next plan, which is what treatments you want to take. So every stage of this involve a professionals that comes together with you, so that the whole idea is to inform patients, to make sure the patients are also well informed. At the same time, doctors also have their own more confident in giving an equitable decisions whether or not to take up genetic testing. So it's an informed decision from both settings from a very beginning. So that's the reason. Another reason is also because the components of ARiCa is all medical data. So we have age of diagnosis, we also have a tumor types, which are all medically that has been pre-collected in hospital setting. It's something that doctors can key in. And then once you have the results, they do understand how. So of course, clinicians will be trained on how to use ARiCa. And we have also clinical, of course, they'll be trained how to use it, and then apply it in a clinical setting where patients will get access to those tools in a clinical setting. So it's not something that patients can directly access. The best is to go through a clinician's.
Right. So if the clinician recommends that you use ARiCa, then only you get the chance to use ARiCa, right?
True.
Okay. And then if any further step needs to be done, then you will be referred to a genetic counselor.
True. That's another step. It's also accompanied by another professional.
Okay, seems like a very straightforward procedure. And so since you said about doctors being trained, I don't think that I don't assume that ARiCa is currently being used in many hospitals across Malaysia, right? I think in only certain places.
Okay, so basically so going back to the history where ARiCa was first started development back in 2019, and then we published it in 2022. And then what we did right after the publication is that we have a genetic counseling team who actually put an effort to integrate these tools into a user-friendly web interface website where you can access login. So we need a login, personalized login, and then where doctors can actually calculate the personalized risk score. So basically, this is designed, again, as I mentioned, this is designed for clinicians to use so that they can use it for their consultation while they are seeing the patients in a clinical setting. So again, this interface at the moment is research use only. So of course, our next goal is because we have run a clinical trial, we have completed, and we found that it is user-friendly. It has a good feedback from the clinicians. So our next goal is to make ARiCa readily accessible to more clinicians across Malaysia. And we have a launch targeted early next month, where the main purpose is to encourage the adoption of tools among clinicians, not to say among breast cancer patients or among healthy individuals, but I think among clinicians, many probably not aware of the existence of ARiCa. So one of the main reason is also to actually launch this officially and to let people know there is such tool called ARiCa where you can use it to make a decisions together with your patients, whether or not you want to refer your patients for genetic testing. And it's in a way to raise awareness about the importance of genetic tests, and there is an option for you, a tool that can help you to decide whether or not you want to take up. And the whole idea is, while we're slowly blending in and having more people to use it, more clinicians to use it, that in the end of the day, the picture is that to have it integrated in a clinical setting, in existing clinical workflow, so that will be part of your consultation as part of the system. It's like part of the system. Yes.
So usually, I mean, because we are spreading awareness right now, is it like, I'm just wondering, is it like, do you have to like go to certain hospitals and propose the idea, or do you just wait for hospitals or clinicians to approach you and say that, oh, I'm interested in this ARiCa thing, like maybe we wanted to use it in our hospital? So which one does it happen?
I think it has to go through the hospitals first. So it has to be.
So you have to approach them first, or do they like approach you?
I think the whole idea is to mainstream it. So mainstream it to where it should, if it's already integrated, where the clinician already start using it, technically, their patients who they're seeing should also get access to the ARiCa automatically. Yeah. It should be through the clinician. So of course, the integration has to happen first for the clinician to have access to this ARiCa, where the patients will get access. It's not like patients will request, but patient can request provided that ARiCa is being integrated in the hospital, right? So that's our aim is just first is to have clinicians aware of these two first, so that we can start to integrate in the clinical workflow. Once it's integrated, that's when patients can get access to it, like when
right, because right now it's not available in all hospitals. So if you actually do want to use the ARiCa tool, you will have to go to a specific hospital here in Malaysia in order to get it, right? Something like that, but not necessarily, because again, it depends on the clinician's
decision. So at the moment, if you want to access probably directly with us, Cancer Research Malaysia, because we are the one who developed, so we have it. But if it's through a proper way, like mainstreaming, of course, when it's properly integrated into clinical setting, when clinicians start using it. So probably after launch, we will see more people talking about ARiCa, more clinicians taking up the use. Then you can see wider usage in the clinical breast cancer setting.
Do you have how many hospitals are currently using ARiCa right now? Like
not at the moment. Not at the moment. Because we have tested out only in for a research setting. We have a couple of hospitals that we have worked with for research purpose. So, and from that, we realized that, okay, ARiCa is good to go, because clinicians do think it doesn't take up so much of their time. They think it's a lot easier for them to use, and they find it's user-friendly. That's a very important thing, because we need clinicians to actually agree to use it, because consultations can take some time. When you want to fit in another additional consultations, you probably want to make sure that it doesn't take up too much of time, it's easy to use, and also user-friendly. That's one thing that we have really confirmed through our trial studies. So the next step is, because of this, we are more confident to have it launched officially, so that more clinicians will take it up and be part of the use it part of your consultations. So that more.
So another important factor, which I think people might be concerned about, is the accuracy. Like, how accurate is it? I'm sure that people say, oh yeah, it's easy to use, it can be accessible, but what about the accuracy? Like, how accurate is ARiCa in terms of calculating my risk factor?
True. Okay. If you talk about ARiCa and why we came up with our own models? Why not existing models? Again, ARiCa is novel in a Southeast Asian setting, but it's not novel globally, worldwide, because
Yes.
we do have models that has been built in Europe. Again, Europe always starts. That starts the
Always,
process.
always, yeah.
So they have these models. There are plenty of them, but again, there, as I mentioned earlier, because of the differences that we see in terms of age of diagnosis. For example, we do see a younger age of diagnosis in our setting. And we also have a different mutation prevalences. So for example, just give an example, like BRCA1 and BRCA2 that we are talking about throughout this session, we do have a different prevalence. If you look at from a European setting, there are more BRCA1 compared to BRCA2. In our setting, we have more BRCA2 than BRCA1. So if you were to really apply their model that has been mathematically calibrated for their population directly into our population, the accuracy probably not as good. They're not so as sensitive to detect the carriers in our setting. So it's like you're asking everyone to wear shirts and suits and not kebaya, cheongsam, or sari. So
yeah, I think another way it's like say for example, just to show people what is the stark difference between us culturally and also genetically. It's like, say for example, it's like they tell you to eat like bread instead of rice. You know, of course we'll be like, what? You know, that's like impossible for us Asians. We need our rice, right? So and then if we tell them to eat rice instead of bread, they're going to be confused. They say like, oh, why would I want to eat rice for? So that's like, it's really different. So I think we can all see the problem over there, because they created like something that is meant for Europeans. So if you try to force that European standards into our Asian society, it's not going to work, you know, because there's like, we are all different culturally and, you know, mentally, the way we think, and also the way we are built from head to toe, you know, from the hair to our toes. Yeah, it's just not going to work at all.
True. And I think because of this also, I think many are missing the chance if you were to apply their tools directly. What we have done is earlier in our paper, before we even developed, we also validated some of the well-known models, some of the most comprehensive model built in UK's and Europe population. We found that the accuracy is as low as 20%.
20%, wow.
Yeah, you're missing out 80% of the population that is might be very lethal kind of mutation. So, and then that's one, it prompts us to actually build the model from scratch and have the data that we have collected over the 20 years. Cancer Research Malaysia have collected one of the largest data. So these breast cancer data set, which allow us to actually build ARiCa from scratch, develop and validate it. And when we compare, the accuracy is well fit, a lot higher, way higher compared to Europeans. While European tools works well in their setting, but it's less accurate in our setting.
That's actually really interesting.
Yeah.
So that means that what we have to
differences.
start, that means we have to start questioning about everything we know right now, because in the healthcare setting, we like to take a lot of things from the Americans and also the Europeans. You know, they have like treatments, they have machines, but then we have to really start questioning, is this really going to work on us or not? But then it also places quite a huge burden or a responsibility on us Asians, that we have to start like working on our own, you know, for our people. So we have to like stop relying so much on like the Europeans and basically the West for, you know, our treatment, because in the first place, it's not going to benefit us 100%. I mean, it's just like, maybe like you said, like 20%, 10%, it's very low. But you know, unfortunately, it's just like that. We are different in our own ways, you know, genetically, and it is what it is.
True. Yeah. So
very interesting. Yeah, we should all definitely start to question this, you know, because I'm sure that all of us here wants the best for our health. We want to live a happy and healthy life. So yeah, I don't think that personally speaking, I don't think that we should you know, cut back on anything when it comes to health, because health is not something that you can buy in the first place. So we have to take it quite seriously. Yeah.
True.
Okay.
Yeah. I think that's the whole idea. Even it's not just our Cancer Research Malaysia CPPS team, our prevention team. But I think a lot of treatments is also now we're trying to customize it to our own setting, because we do see some differences. That's the whole idea of this research also. So to personalize it to Asian, we're thinking that probably some of what we know probably doesn't apply to us 100%. That is just not for genetics. It can be for lifestyle and reproductive, many other things. I think it does matter to take into consideration of these differences. Yeah.
Okay, interesting. Okay, so wow, so far we have spoken a lot about many things, but I have one last question for you, Boon Hong. Okay.
Yes.
All right. So I want to know if there are any plans or goals for ARiCa in the future.
Okay, so the one of the goals that I already mentioned, so the idea is to launch so that more people
Yes,
will be aware,
launch.
not just clinician, but also many general population will be aware there's existence of these ARiCa. And
Yes.
other than that, I think because we also have these analytical studies that we have done since 2022, is that we have clinically evaluated ARiCa both in terms of utility, whether it's user-friendly among clinicians, and also the impact on the genetic testing uptake. So we have completed this study, and we also have just completed improvement of ARiCa. So we're also actively trying to improve the accuracy, though it's not a perfect model. So we are trying to improve the accuracy while balancing
Yes.
the resources that we have. And we have also completed these 2 studies. So moving forward, the plan is to wrap up these studies and also potentially get the publications out. So that's one. In parallel to that, we also recently validated ARiCa in other Asian population, which is more interesting because these ARiCa is built based on Malaysian and Singaporean, so it's Southeast Asians. So we also have the plan to actually validate it in other Asian population, not just Southeast Asian, but potentially other Asian partners. So plan is to extend the collaboration. So currently we have validated in Pakistani population. It's the South Asian population, different from Southeast Asian, though. But we found that ARiCa works well in their population. So we published a paper this year.
Very surprising. They're like on the other side of Earth.
Correct.
Not
So
too
we
far,
found
but still,
true.
South Asia.
So
Yeah.
yes, and it works
Interesting.
well. It works well. So we thought of, okay, initially we thought it's just Southeast Asian, but now we think that probably we should also consider other Asians. So moving forward, probably expand these collaborations to other neighboring and also other Asians, and so that more
one step at a
patients,
time.
yes, and patients can access this. That's the next plan for ARiCa, though.
Interesting, yeah, because usually when we talk about Asians, there's like a lot of many Asians, we're talking about Southeast Asians, we're talking about East Asians, and then there's also South Asians, and then there's the people from the Middle East, and then Central Asia. So each and every one of us are very different because Asia is such a big continent. And of course, I mean, Malaysia is not the only one who's conducting research on its population regarding health, but also many other Asian countries. So I think it's actually really surprising to know that some of ARiCa actually works for the Pakistani society, the population. That's actually really, really interesting. But it would be great if like Malaysia can like establish further connections with other countries and collaborate on a project that can actually benefit their countrymen and countrywomen. Overall, I think that would be great, actually. That would actually be really, really great. It actually builds like rapids, it builds like a sense of community among the Asians, that would be actually really great. Yeah. Awesome. Yeah, so hopefully, I mean, I'm surprised that ARiCa is still quite new because you said that it was just in 2022, right? So that was 3 years ago. 3 years is very short for a project like this, especially in science. Science usually takes a very, very long time and also a lot of money. A lot of resources have to go into research. But yeah, I think we have learned a lot about ARiCa today from you, Boon Hong. So that's really fantastic. So thank you so much for actually telling us all about this.
Thank you so much for having me.
Yeah. So now we can move on to a Q&A session. So if there are any questions from our attendees today, feel free to drop it in the chat box and we will do our best to answer you. So we'll just give them maybe 1 or 2 minutes to write them. messages. If there is nothing, then I'm gonna assume that there are no questions. Everyone is absolutely clear on what we've been talking about today. That'd be great, yeah. So if no questions, then we can finally move on to the next part. But let's just give them maybe another minute or two. Oh, so one from Adeline. How can we be involved with the ARiCa research? Oh, involved. Yeah, this is for you to answer, Boon Hong.
Yeah, we have just completed the study. We have wrapped up the study, so there's no actually ARiCa is free too, for your information. So once it's properly launched and once clinicians start using it, it's free. It's free. It's a free tool.
Free.
Yes, it's a free tool.
Wow.
It's clinically integrated. So we want more people to have, the whole idea is raise awareness about genetic testing. So not many people are knowing it. So I think once if it's integrated in a clinical setting, so it will be a free tool where clinician can access and both patients and clinician can make
Interesting.
informations with ARiCa. So it's a free tool.
Okay, so hopefully that answers your question, Adeline. Right, do we have any more questions? No? Nothing. They're quite quiet. I think maybe they understand. Hopefully we've been clear. I mean, that's the whole point of the webinar in the first place. Is
You made it clear.
Thank you. You did a very great job in explaining to them as well. It's great, actually. I just broke it down into a simpler terms. That's all I did. That's my role after all. Okay, seems that we do not have any more questions from the audience. Now we can, now I will talk about the e-certificate, which people are usually more interested in. So I'm going to share something right now. Hold on, let me just give it a quick share. Okay, so I'm sure you can see as well, right, Boon Hong?
Yep.
Okay, so here are the details on our webinar e-certificate. And I always say this every time at the end of our webinars, but let me just go through it with you if you're a first timer here or if you're still unclear on how the process is. So you will receive an email in your inbox one day after today's webinar. So today is the 15th of October. So tomorrow on the 16th, just make sure to check your inbox. It could be in your junk mail. So in the email itself, there is a link to a feedback form. So all you have to do is just click on the link, you fill out your information, and at the end of the form, there is one part which mentions about the e-certificate. So if you want it, you just click yes. If you don't want it, you just say no, and then that's the end of the form. So if you do want an e-certificate, just to, have your name on a very nice certificate, just to show that you attended one of our webinars, just fill out your details. And then you put your proof of donation because we do require a minimum of 1 ringgit donation. Just 1 ringgit is the minimum. So you take a screenshot of the transaction, you put it there, and then you should be able to get your e-certificate within 30 days. So if you still haven't received it after 30 days, which is about a month, just feel free to email us at the email address provided below, which is de.comms@cancerresearch.my. So keep in mind of this email, because if you email any other email addresses, it's just going to be a bit annoying, but this one is the right email address. So if you want, you can take a picture of this e-certificate detail, and then because I'm going to stop sharing shortly anyways. Okay, so just make sure of that. All right, so I'm just going to stop sharing now. Okay, so I think that wraps up for our session today. It's been like a really great 48 minutes speaking to you, Boon Hong. I think it's been a very fruitful session. So again, so thank you once again for taking the time, your precious time to actually speak with us for about an hour. I'm sure that the people here really do appreciate, what you have spoken to us, and hopefully they will be thinking about, more about the issue that we are currently facing here in Malaysia a bit more after this webinar ends.
Sure. Yes, thank you for having me. Thank you so much. Thank you so much.
Yeah, thank you. And I hope you all have a wonderful day ahead. and enjoy your lunch because it's almost 12 o'clock.
Yes.
You have to go makan. Okay, so all right, thank you so much, all of you, and goodbye. See you then. See you next time.